illness under the topic. So we're all clear. All right. I got these from a part of this is a collaboration between myself. There's a EMS coordinator at Dignity Health, a couple of athletic trainers in the East Valley, and a ER physician that works for ValleyWise and University of Arizona Medical School. So we're going to dive into it. If we don't get through all of the slides this class, we will try and get through the rest of them next class. Let me set a timer for 35 minutes. I'm going to give you a break and then we'll come back because this is intensive. All right. In the United States, there are something like 67,000 emergency department visits, about just over 9,000 hospitalizations, and just about 700 heat-related deaths annually. In Phoenix, in and around Phoenix, we have last year we had about 145 days of greater than 100 degree heat, which brings the question that in Phoenix there is a particular problem with heat illness. So when we talk about heat illness, the big thing that helps us determine if someone is in something called heat stroke, which is part of heat illness. There are a handful of types of heat illness. We have heat cramps, where if you've ever gotten a cramp while exercising, heat syncope, where you pass out, heat exhaustion, and heat stroke. For heat exhaustion and heat stroke, specifically heat stroke, we use core temperature as one of the two main symptoms that we use to differentiate if you have heat stroke or if you have heat exhaustion. The way that your body produces heat is through your metabolic heat production, so your body doing things regularly, pumping blood, contracting your muscles, things like that. And then you also have this other part is mechanical work. So let's say you're outside exercising, right? That's doing more work. And then you subtract the heat exchange. So when you sweat, that evaporative cooling that happens, that helps your body cool itself down. And so that's how we kind of get the basic formula for your core temperature. When you regulate your temperature, when your body regulates its temperature, there's a couple of things that happen. One is vasodilation, so your blood vessels dilate, get larger. You start to sweat, so once you sweat, when the sweat evaporates, that helps your body cool off. And then you have tachycardia, which is an increase in your resting heart rate. So your heart beats faster, you sweat, and your blood vessels dilate. And that's how we help regulate your body temperature. When you are in heat stroke, these three things go out of whack. We can have, in the extremes of heat, you may have an inability to sweat. You may be at kind of the top of where your heart can beat faster, and you might not be able to vasodilate any more than it already has.
Wait, what was vasodilation again?
Vasodilation is where your blood vessels get larger or expand.
And tachycardia is what?
Tachycardia is an increase in your heart rate. Technically, it's a technical term for the speed of your heart rate, but for our purposes, it's just your heartbeat is beating faster. When you have a patient who has diminished cardiopulmonary reserve, so the ability for your heart and lungs to exchange oxygen, any extremes of age, and if the patient is taking certain medications, it can affect their ability to regulate their body temperature as well. So when we want to adapt to our environment, and you can see on this slide there's a call out for whether this information may or may not be important. When we adapt to our environment, it occurs and can occur, we much like weight training, we can adapt to higher temperatures, higher mechanical works, higher loads on our body. So we can have patients adapt at about 1 to 2 hours over about 10 to 14 days, and this can be a relatively safe way to adapt to the heat, making sure that they're not overexerting themselves. And these adaptations can persist for a month or two, just from these 28 maximum 20 to 28 hours in the heat, exercising in the heat. And so we have that increased, once we have this exposure, we're exercising in heat, we're going to have that increased ability to tolerate and distribute that heat. Any questions on any of this stuff so far? All right. So when we try to diagnose heat illness, there's a couple of different things. First, the time in which it takes us to diagnose particularly exertional heat stroke is very critical. Because as you can see on this chart right here, this is chance of survival. This is amount of time in heat stroke. And the longer it takes, the longer a patient is in heat stroke, the less likely they are to survive. So really, after about, we can see here an exertional heat stroke is in blue, and then we have passive heat stroke here in red. An exertional heat stroke, if it's identified within 15 minutes, our chance of survival is above 80%. But once we get past that 15-minute mark, our chance of survival drops to right around 50, and then if it even goes beyond 30 minutes, we're down just above 20. So the likelihood of someone surviving is critical. Here's what we're going to do. Let me bring this up. There we go. So this is another kind of simulation where we have a range of where we identify exertional heat stroke. If we identify it at about 5 minutes, at about 10 minutes, or at about 30 minutes. This gray area right here is where a patient survives and without any kind of long-term consequences. If we have that optimal recognition and on-site treatment with cold water immersion, the chance of survival for patients is nearly 100%, and we'll get to outcomes much later. But what also you may be able to see is heat illness and heat stroke. This is a table of a bunch of symptoms and varying diagnoses. You can see that exertional heat stroke crosses with a lot of different diagnoses, and that's why in my world we have to use rectal thermometry and core temperature in order to be able to accurately diagnose exertional heat stroke. So the diagnostic criteria for heat stroke is a rectal temperature of above 104 degrees Fahrenheit and central nervous system dysfunction. So that's disorientation, confusion, dizziness, loss of balance. Yes, Kelly?
Wait, why do you have to do that?
Why do you have to?
It's like, I understand when you have to do that for animals, but why?
We will get to that just next, okay? So, I have seen in patients, they feel cold, they stop sweating. All of these are signs of heat stroke. And it's important that if you recognize signs, that you need to get that person either into a cold water immersion bath or into as effective methods of cooling as possible. So to answer your question, Ms. Powell, we have done research on if we can use other methods of testing temperature. So they took a couple of patients and they had them test a smattering of different ways to try and test their temperature. Using oral, ones in their ear, tympanic ones that you might have seen the nurses use on their head, a lot of different ones. So first let's look at oral, most common one. So here on the top we have our rectal thermometer, and then here down below we have our oral thermometers. There's a difference of 4 degrees Fahrenheit. That's a difference of 104 and 100. So it's either diagnosing or not diagnosing. Well, what about temporal? That one's also terrible. Another 4 degrees Fahrenheit difference. We can't use that one. Well, what about using tympanic? Delta of 2. So that's a difference of maybe 102 to 106. And the way that I'm going to treat a patient with 102 degree temperature versus 106 is going to be completely different. So tympanic's out. And we can see, here's oral, delta of 2 degrees Celsius. Still terrible. We still can't use this. So what I'm trying to say is rectal thermometry is the only valid measure that we can use to diagnose heat stroke and to actually demonstrate if someone is in or is not in exertional heat stroke. Many high schools in this country do not use rectal thermometry. They should. Most colleges now will use rectal thermometry. Most emergency medicine crews, most EMS crews will not use rectal thermometry. They should. Catherine.
What's the difference between passive and exertional?
So passive heat stroke is going to be more like you're standing outside. You can think of our houseless population, right? You're just out in the heat and you just can't cool yourself off. Versus exertional heat stroke is going to be more like you're outside, you're working hard, you're exerting yourself. Any other questions?
So is it just we're using that method because it's more reliable?
Yes.
And like it doesn't change person by person, or like?
Yes, so it's the most reliable, it's the most valid, and it gives us the most accurate data. So we'll get into it when we cover treatment, but I'll jump ahead just to answer your question. When I have a patient who their core temperature is above 104, I'm going to put them into a cold water immersion tub. Then once their temperature is about 102, I take them out. And that's because they will continue to cool. And if I keep them in there too long, then they're going to go into hypothermia instead of hyperthermia. Make sense? All right. Thank you for that question, Aaron. Any other questions? All right. So then what is kind of best practice? Well, we have a consensus statement right here for emergency medicine. You will see this name right here, Doug Casa, a lot. throughout these slides. We can also see that in the National EMS Treatment Guidelines, they have for exertional heat stroke, rectal temperature is greater than 104, altered mental status, cool by ice bath immersion. If ice bath immersion is not available, use taco, rotating ice-soaked towels. Continue to cool until they're at 102. So, then up until actually this past year, Arizona EMS, Central Arizona EMS did not have this section at all. They weren't doing cooling. It was not recommended. But now we have language to include the option now to continue cold water immersion. So it specifically says consider maintaining cold water immersion if already started with online medical direction. Previously, the recommended care was to put them in the back of the truck with AC and hook them up to a cold IV. Those don't cool you fast enough. You will have long-term damage from heat stroke if you don't effectively cool someone. You can have kidney damage, brain damage. The lifetime costs for someone who has had a bad outcome from heat stroke is about $1 million. If we treat it properly, a tarp costs $20, treat it with ice and water, and save someone $1 million. Let's talk about treatment. The standard of care practices. This is somewhat football centric, and this was surveying athletic trainers about high school athletic trainers for football. Standard of care practices: you remove the equipment, you immerse them in ice water, and you take a rectal temperature. That is the standard of care. The additional steps that you may take to cool an athlete: moving them to a shaded area, used ice towels, move them indoors, remove their clothing, cool them with a portable AC unit, and then calling emergency medical services or calling for additional providers. So let's look at some different treatments that we can do. When we look at various treatments that have been investigated and summarized into one table, we can see on here a lot of different methods of cooling. We have ice packs to the major arteries all the way down there. We have tap water immersion. We have water and air spray. We have wet gauze. I like this one the most: helicopter downdraft. That one seemed like a very expensive study to run. And then kind of everything on this side of the line, where we have the effective cooling rate of about 0.15 degrees centigrade per minute, is all cold water and ice water immersion. Probably from most to least, we're going to have ice water immersion, cold water immersion. You'll have tarp-assisted cooling with oscillation, and maybe even an acceptable one, hand and feet water immersion. These are looked at to see if we can cool someone from 108 down to 102 effectively within 30 minutes.
What's BCU?
I have no idea. So when we take someone down from heat stroke, it's about 1 degree for every 3-ish minutes with some good assumptions. So that's assuming the water is between 55 and 65 degrees. You're oscillating it. They don't have, they're not a big football player with all their equipment on. You have adequate staff and the like. So when we assess a patient with rectal thermometry, what we can do is we can calculate at that initial evaluation how long they're going to have to be in the water. So for 104, it's about 15 minutes. So when I talk about the TACO method, TARP-assisted cooling with oscillation, we're taking about 10 gallons of ice, 20 gallons of water. We're taking them to the shade. We're putting them on the tarp, pouring the water into the tarp, and then we're oscillating it around the athlete. A relatively easy and inexpensive way to do cold water immersion. It has been shown to be around as effective. It's above that 0.15 degrees Celsius per minute, and this can save people's lives. We also have another cool device called the Polar Life Pod. I don't have one of these, but kind of similar idea to if you don't have a large cold tub like we have just outside my office. You put the patient into the pod, you fill it up with water and ice, and then you monitor them. This costs, I think, like 3 or 4 times the cost of my 150-gallon stock tank. So I'll go ahead with my tarp and stock tank rather than one of these Polar Life Pods, but that is my opinion. Any questions on treatment? All right. Hospital response. So there, up until fairly recently, in the emergency department, they would not do cold water immersion. And for a long time, it was controversial to do cold water immersion because there was a hypothesis that you would send a patient into shock if you did it. As you'll see later, that is not the case. But then in the hospital, there's a similar way that they end up treating these patients. And Dr. Kamp, who is at ValleyWise, they've kind of pioneered this in the Valley. First, we got to remove them from the environment. Same thing that we're doing out in the field. And we also have to address additional concerns. So if they make sure they have an airway, make sure they're breathing, make sure that they don't have an open wound, things of that nature. And make sure that we're providing supportive care, resuscitation, and then they're cooling them. When patients present to the emergency department, a lot of times the physicians do not know if they are on medications. When a patient has a fever, when their core temperature is elevated, there are some inflammatory cytokines that are produced, and we can inhibit some production of, we can use some medications to help reduce the fever, but generally speaking, those are going to take a lot longer to kind of help the patient out. It's going to take much longer than that 30-minute window that we have, and so that's where we need to have active cooling come in. Previously, we have had people use means of passive cooling, so you can think of, the fans, the spray fans with like water. You can do some cold towels. You can do air-conditioned room. Whereas more active cooling, you are using a lot more ice water immersion. You are using more ice packs. You're using those almost freezing towels. Using evaporative cooling, cold packs, IV fluids, all can help in part in the emergency department to cool that patient. When you switch to cold water immersion versus some of those other techniques, so the cold IV, the medications, the cold packs, evaporative cooling, ice water immersion is about 24 times more conductive than air. And so we are going to be able to take a lot more heat out of that person's body compared to just keeping them in an air-conditioned room, say. And compared to, say, evaporative cooling where we're spraying them with water, it's going to be significantly faster because we have so much more thermal mass that we are exchanging that heat with. So here are the steps that they do in the emergency department at Valleywise to treat patients with hyperthermia or heat stroke. Let's go back. They use body bags, so same bags that they use when to bag someone up when they are deceased. Works just as well. A little bit morbid, but that's okay. Then they get some ice from their cafeteria. They move the patient into the bag. They start pouring the ice and water in, and then they continue monitoring the core temperature, and then when they're all done, they cut the bag at the bottom and remove the water and log roll the patient out. Here is a picture of when they're doing that. This is just an example. This was just for like training purposes. So when the patient is in the emergency department, some of the things that they have to take into account is, do they need to get this patient into a CT scan? Do they need to get this patient into another room? How are they going to do that? And how are they going to do that now with a patient on a bed with several gallons of water and ice all around them? And they're going to end up treating concerns. So imaging, oftentimes they'll do labs, make sure they're monitoring the patient, and if they need to resuscitate the patient, and they have to maintain, it's called an open differential, so their differential diagnosis, is this exertional heat stroke, is this something else that we are missing? Patient's disposition for mild heat-related illness, they're not going to really see these in the emergency department. Patients tolerate this kind of treatment in the emergency department well, and there's not a lot of adverse outcomes when you use cold water immersion. So, got to remember the signs and symptoms of our heat-related illnesses, making sure they're trying to make sure that they're not treating, say, heat syncope the same as they would exertional heat stroke, the same as they would heat exhaustion. While they're kind of all on the same spectrum, the labs and the imaging are going to be different for each one of those. They're trying to diagnose and treat rapidly. Like we saw earlier, treating patients within that 30-minute window can help survivability. And they're also thinking about treatment strategies. Any questions on emergency department stuff? All right. Let's take 5 minutes, and I will have you all come back and we'll talk about prevention.